So can you see the slides now?
Yes, we can.
Okay. So we will talk about supraventricular arrhythmias, including atrial fibrillation, atrial flutter, and supraventricular tachycardia. We will start by reminding you what the normal sinus rhythm looks like. In normal sinus rhythm, the initiation of the electrical signal takes place in the sinoatrial node, in a sinus node, at a rate that is appropriate to the age and state of activity of the individual, with a range of normal heart rates in every patient. And the propagation of this signal takes place in an orderly manner through the atria and then to the AV junction and through the His-Purkinje system with this ventricular specialized conducting system to the ventricular myocardium. And usually, if no conduction disturbances are associated, the complexes, the QRS complexes, are narrow, and there is a P wave that precedes every QRS complex. And the rhythm is regular. When we talk about supraventricular arrhythmias, they include all the rhythms emanating from the sinus node that may be abnormal, from atrial tissue, and we'll talk about atrial tachycardia, atrial flutter, and atrial fibrillation, and also from the atrioventricular node, from the junctional tissue, including those tachycardias that imply the presence of an accessory pathway in some subjects. You should know that supraventricular arrhythmias are relatively common. They are often repetitive. The patient has multiple episodes. They are occasionally persistent, and they are rarely life-threatening. While sustained ventricular arrhythmias often cause collapse or death, these sustained supraventricular tachyarrhythmias usually permit the maintenance of an adequate cardiac output, especially in young individuals. By definition, a tachycardia is present when the heart rate is above 100 beats per minute at rest, and the mechanism of a supraventricular tachycardia involves tissue from the His bundle and above. Traditionally, SVT, supraventricular tachycardia, has been used to describe all kinds of tachycardias apart from ventricular tachycardia and atrial fibrillation, so SVTs are discussed separately in the guidelines. There are separate guidelines for SVT, supraventricular tachycardia, and atrial fibrillation. But we will discuss both today. The conventional classification of supraventricular tachycardias include the atrial tachycardias that have the origin in the atrial tissue, the sinus tachycardia, which can be inappropriate or physiological, and the sinus nodal reentrant tachycardia, the atrial tachycardia, the focal one, and the multifocal atrial tachycardia, the atrial flutter, which is a macro reentrant atrial tachycardia, and atrial fibrillation. Then there are atrioventricular junctional tachycardias, the atrioventricular nodal reentrant tachycardia, and atrioventricular reentrant tachycardia that implies the presence of an accessory pathway. So these two, atrioventricular nodal reentrant tachycardia and atrioventricular reentrant tachycardia, are distinct entities, but they are both supraventricular tachycardias. So what are the main electrophysiological mechanisms that can lead to an arrhythmia? You will talk about these mechanisms also tomorrow in the ventricular arrhythmia course. There is the abnormal impulse initiation that takes place in some clusters of cells that basically and normally they do not produce an electrical impulse. But when there is enhanced or abnormal automaticity and early or delayed after depolarization of the membrane, the abnormal impulse initiation can take place. And this process may be facilitated by ischemia and some electrolyte disturbances like hypokalemia and increased sympathetic drive in some patients. On the other hand, there are re-entrant arrhythmias that are based on these circuits in the myocardium, these loops that are formed between different myocardial regions that are activated later in the propagation of the impulse and re-excite regions that have already recovered their excitability. And these circuits, these loops form in the myocardium. There may be a micro re-entry or a macro re-entry, like we have in atrial flutter. So these are the two main different mechanisms of supraventricular tachycardias: non-reentrant and reentrant. And this is very important for the treatment, because the treatment is different in these cases. The clinical presentation, the clinical picture is, in all cases, it varies, because the symptoms may be very light or the patient may be asymptomatic. The patient feels palpitations, he may be feeling dyspnea at exertion or lightheadedness in the episode of palpitation. They may feel a sensation that seems like angina or chest discomfort, and in severe cases, they can present for altered consciousness, and in extreme cases, with cardiac arrest. Rapid rhythms are more likely to present with a clear history, and the patient feels that an episode of palpitations has an onset that is very sudden and acutely, than less rapid rhythms that may be mostly asymptomatic. But SVTs usually produces a symptomatology that is clearly related by the patient. It's important to ask the patient which is the duration of symptoms and the patient's age at onset of these episodes, because an individual with an onset in the teenage years or younger points towards a re-entrant mechanism that is frequent in this age range. Dyspnea or other clinical signs and symptoms of heart failure can occur lately in the process when the patient has already developed a cardiomyopathy induced by the rapid heart rate, and it is called a tachycardia-induced cardiomyopathy if this occurs. Lightheadedness in association with SVT is not infrequent. The patient may feel like he's going to faint, or what's called a pre-syncope or even a syncope. They are less common in younger patients, but in elderly patients, they may be a frequent mode of presentation, because these older individuals have drops in blood pressure that are usually immediate upon the onset of the tachycardia. They recover rapidly after the termination of the tachycardia, but the clinical picture may be dramatic in some patients. In some patients, we may have polyuria, possibly due to the atrial stretch induced by the atrionatriuretic peptide activity. And even the risks that are associated with supraventricular tachycardias are not so big. This is unusual. There are specific situations, for example, in patients with a VPV, WPW, Wolff-Parkinson-White syndrome with a pre-excitability and atrial fibrillation or after some interventions in the atrial switch in congenital patients. These supraventricular tachycardias may lead to sudden cardiac death, but there are very rare cases and specific situations. So when we are in front of a patient with palpitations, we should ask which was the clinical context of initiation of the cardiac episode, how long does it last, under what circumstances did it appear, is it a regular or irregular kind of palpitations, if the patient can give us this information, it is important. And also how fast is the heart rate during the crisis, important for the differential diagnosis. The differential diagnosis, especially in younger individuals, has to be made with a panic attack or a state of anxiety. If the arrhythmia has a sudden onset and termination, if it's triggered by a change in the patient's posture, and the tachycardia seems to be regular, and the patient can feel it like a regular, rapid rhythm, and if the palpitations are suddenly interrupted after performing some specific maneuvers, like vagal maneuvers, or drinking a glass of very cold water, this points to a re-entrant arrhythmia. And also, it's important to ask the patient, what about the episodes in the past, and if there are any drugs that had a favorable response in the past, like adenosine and verapamil, because this also should point to a re-entrant arrhythmia. And usually, the patients that had a lot of episodes know that these are efficient or not. So the initial assessment of the patient with palpitations and with when you have a suspicion of supraventricular tachycardia should be made by history, physical examination, of course a 12-lead ECG. An ECG during the tachycardia is very important and should be always sought. A transthoracic echocardiography should be performed to see if there is a substrate for the tachycardia. In many patients, the cardiac chambers are not enlarged and there are no valvular lesions, so the transthoracic echo can be normal. And also we should perform tests of thyroid function. Hyperthyroidism can entertain these episodes, and it is very important to treat any dysthyroidea in these patients. And there are some optional tests that can be performed, like ECG monitoring, Holter monitoring, or even transtelephonic monitoring in patients that have rare episodes of palpitation, or even an implantable loop recorder in patients that have infrequent episodes of SVT. And also, in patients with cardiovascular risk factors, it's important to rule out myocardial ischemia, and we should perform myocardial ischemia test by ECG stress test or echo stress test. And of course, if there are many episodes and we are thinking about catheter ablation in some patients, an electrophysiological diagnosis and an accurate diagnosis. So the ECG is very important. And if we have an ECG recorded during the crisis, it is very important to have in mind these criteria that are important for. So the regularity of the tachycardia is important. Is it a regular rhythm? Also important to detect, and also the morphology of these P waves is important, and the relationship between the P waves and the QRS complexes. We should also measure, if we can see a P wave, we should measure the RP interval and the PR to see if the tachycardia is with a long RP or with a short RP, because this is important for differential diagnosis. Some tachycardias have a short RP interval and some have a long RP interval. You will see in the next slides. And also to classify, broadly speaking, to classify the supraventricular tachycardia and the tachycardia itself, you should see if the complex, the QRS complex, is narrow or wide, and this is very important to measure the QRS complex. If it is above 120 milliseconds, this is a wide QRS complex, and if it's a regular or irregular tachycardia. In this case, we can see an irregular tachycardia, in this case a regular tachycardia, and a wide QRS complex tachycardia here with a regular pattern. But you should always measure these RR intervals. So the differential diagnosis of narrow and wide QRS tachycardias is very broad. There's a broad spectrum of arrhythmias that are included here. In the narrow QRS complex tachycardia, when the complex is below 120, we can say that the ventricular activation is made through the His-Purkinje system, although there are some ventricular tachycardias with a high origin that may have a narrow complex pattern, but they are very rare. The baseline ECG may provide clues for the diagnosis of supraventricular tachycardia, but not in all cases. The baseline ECG, apart from the crisis, because the presence of a pre-excitation on the baseline ECG is generally suggestive of atrioventricular reentrant tachycardia using this accessory pathway, but the absence of apparent pre-excitation on the ECG does not rule out this diagnosis, because this accessory pathway may be concealed. It may conduct only under special circumstances. So if there is no pre-excitation, it doesn't mean that the patient hasn't had an AVRT. So if the tachycardia is irregular, it can be sinus tachycardia or physiological or inappropriate. It can be focal atrial tachycardia or sinus nodal reentrant tachycardia. It can be an atrial flutter with fixed atrioventricular conduction, but it can also be an orthodromic atrioventricular reentrant tachycardia or an atrioventricular nodal reentrant tachycardia or an idiopathic ventricular tachycardia, especially with the origin high in the septum. If the rhythm is irregular, it may be atrial fibrillation, and this is the diagnosis in many cases, but it also can be a multifocal atrial tachycardia or a focal atrial tachycardia or atrial flutter with a varying atrioventricular block. In wide QRS complex tachycardia, the diagnosis is more complex, is more difficult. The initial diagnosis when we are in front of a patient with wide QRS tachycardia, especially if the patient is unstable, we should think in the first place of a ventricular tachycardia, and we should treat the patient like we treat ventricular tachycardia. But we can also have a supraventricular tachycardia with pre-existing bundle branch block or a bundle branch block that is rate dependent, or we may have a kind of atrioventricular reentrant tachycardia with antegrade conduction through an accessory pathway, and this is important to make the differential diagnosis between this kind of antidromic atrioventricular reentrant tachycardia and VT or SVT with pre-existing block. So these are the entities included in this wide QRS tachycardia. We have a summary of key electrocardiographic criteria that suggest ventricular tachycardia rather than supraventricular tachycardia in a patient with a wide complex tachycardia. If we have atrioventricular dissociation, if the ventricular rate is higher than the atrial rate, if we can see some different QRS morphologies from that of the tachycardia, these are fusion or capture beats. And if in all the precordial chest leads we have a negative complex, then it's possible that we have ventricular tachycardia. The ECG diagnosis is also based on this regularity of tachycardia, and we can say that the tachycardia is regular when we can measure the RR intervals, and these changes between different measurements of RR intervals are less than 15% of the tachycardia cycle length. In these regular tachycardias, we may think about sinus tachycardia, which is a regular tachycardia, and also sinus node re-entry and atrial flutter with a fixed AV block, atrial tachycardia or atrioventricular nodal reentrant or reentrant tachycardia. If the tachycardia is irregular, it may be an atrial flutter with a variable AV block, atrial fibrillation, or focal atrial tachycardia with a variable AV block. So, in the first place, we should check if the tachycardia is regular or not by measuring the RR intervals. Then we should look at the P waves. In this case here, for example, you can see that we are in front of a patient with tachycardia with 150 beats per minute with a narrow QRS complex. It is very thin QRS complex. But we can see here, for example, some notches that are given probably by the atrial activity. So we should check for the P waves or possible P waves and localize these P waves. But this kind of ECG with 150 beats per minute and a narrow QRS complex may appear even in sinus tachycardia in some patients. It can be a focal atrial tachycardia, it can be an atrioventricular nodal reentrant tachycardia or an atrioventricular reentrant tachycardia. So all of these are possible diagnoses in these cases. So the ECG recorded during the crisis is very useful, but it is in many cases insufficient to establish a precise diagnosis. And these patients may need in the future the performing of an electrophysiological study to show the exact mechanism of the arrhythmia to be able to treat this arrhythmia appropriately. This is the case of irregular SVTs. I've mentioned before atrial fibrillation, atrial flutter with variable AV block, and atrial tachycardia with variable AV block, and multifocal atrial tachycardia. These irregular SVTs can have a narrow or wide QRS complex. This is the case of a patient with atrial fibrillation and pre-excitation that conducted through the accessory pathway. These patients are, well, in many cases, these patients are unstable, and we need to perform electrical cardioversion at admission. So finding the clues for the diagnosis includes finding the P waves. If the P waves are similar to those in the sinus rhythm, this points to sinus tachycardia or sinus node re-entry, or a focal atrial tachycardia with the origin near the sinus node, because the P wave can look similar to the P wave in sinus rhythm. If the P waves are different from those in sinus rhythm, we should measure the RP interval and the PR interval, so these intervals that can be either short or long. A PR interval more than the baseline PR suggests focal atrial tachycardia, but these waves may be absent or you cannot discern the P waves, or they may be visible at the end of the QRS complex with a pseudo S pattern in the inferior leads and the pseudo R prime pattern in V1, and this P and this is a type of short RP tachycardia. You can see that the RP interval is very short. QRS complex point. And if we can see the type of tachycardia onset, there are some criteria here as well. The atrial tachycardia may be initiated by a premature atrial beat. And in typical atrioventricular nodal reentrant tachycardia, PR prolongation appear at the beginning of the tachycardia, but not in atrial tachycardia. In the focal atrial tachycardia, when there is one cluster of cells that initiate tachycardia, there is progressive acceleration of the firing rate of the atrial substrate, followed by progressive deceleration with a phenomenon of warm-up and cool-down. This is characteristic for the focal tachycardia. Both atrial and ventricular premature beats may trigger an atrioventricular reentrant tachycardia. And now we should speak I should tell you a few things about different types of atrial arrhythmias. And I will start with the sinus tachycardia, which is the most frequently found. When the heart rate is 100 to this maximum heart rate function of age, which is 220 minus the age of the patient. This is the maximum heart rate that the patient may attain in a course of a tachycardia. So it depends on the age of the patient. Of course, young individuals may have a sinus tachycardia with a very high rate. Common causes, exercise, hypotension that may lead to sinus tachycardia to compensate for the hypotension, hypoxemia, heart failure, sepsis, fever, and fluid depletion and blood loss. And there is also a kind of sinus tachycardia that is considered inappropriate for the subject. When you see a young patient that complains of palpitations and his heart rate at rest is above 100, and these common causes are excluded, then we are talking about inappropriate sinus tachycardia. But you should first seek for these causes to exclude them, so we can talk about inappropriate heart rhythm. The essentials of diagnosis on the ECG, the onset and termination are gradual. The heart rate 100 to this maximum cutoff value for age. The P waves are identical to normal sinus rhythm, and the RP relationship, there is a long RP because the P waves are preceding every QRS complex and they are far from the preceding QRS complex. So the PR interval the RP interval is long. And the management is usually focused on treating the cause of the sinus tachycardia, and in some patients, when we have inappropriate sinus tachycardia, we can use some drugs in order to alleviate symptoms. Ivabradine is one of them, alone or in combination with a beta blocker that should be considered in symptomatic patients. Sinus node reentrant tachycardia is very rare. It implies the existence of a re-entry circuit involving the sinus node and is characterized by paroxysmal episodes of tachycardia. That is in contrast to this inappropriate sinus tachycardia. The patient has some paroxysmal episodes with sudden onset and termination, and the heart rate is not so high as in sinus tachycardia. And the P waves may be identical to normal sinus rhythm, and the RP relationship is also long, like we had in sinus tachycardia. But the treatment, if we can identify this kind of tachycardia that is basically diagnosed by electrophysiological study, we can give intravenous adenosine, verapamil or diltiazem, or we can perform a sinus carotid massage like an vagal maneuver. But the medical treatment on the long term is empirical. Beta blockers are often ineffective, and we can use verapamil or amiodarone to have, but these also can have a rate of success that is not so good in many cases. In some patients where these episodes are very frequent, we may also think about catheter ablation. The focal atrial tachycardia is a rhythm generated by an organized atrial structure over 100 beats per minute, initiated from a discrete origin and spreading over both atria in a centrifugal pattern. The axis of the P wave gives us information about the origin of the tachycardia. The tachycardia has a sudden onset and termination, and the heart rate is below 200, so over maybe 180. And the P wave is different than that we found in normal sinus rhythm because it's an ectopic structure that generates the impulse. The RP relationship is long, the RP interval is long, and the ventricular varies with a degree of AV block. So you can see these P waves here preceding the QRS complexes. And it looks like sinus tachycardia, but these P waves are different than the one that we see in a sinus rhythm. And there is also one kind of multifocal atrial tachycardia that is mainly related to pulmonary disease and COPD exacerbation and acute heart failure, and may be provoked by some external factors like pulmonary embolism or valvular heart disease, or in conditions of hypokalemia. The heart rate goes up to 150 beats per minute. The P waves, there are three distinct P wave morphologies in a single lead, like in this case. Then you can see that the P wave here looks like this, and it's not similar to this kind of P wave here or here. So we have more than three distinct P waves in a single lead. The rhythm is irregular, and we have of great variability regarding the PP, PR, and RR intervals. So this is multifocal atrial tachycardia. The atrial flutter is the second most frequent atrial arrhythmia after atrial fibrillation. It affects 80% of these patients with flutter are male. And this is a macro re-entrant tachycardia. Depending on the site of the origin, it can be typical or atypical, as we will see later. The atrial rate is about 300 beats per minute, and the ventricular impulses are transmitted at some integral fraction of the atrial rate. In rare circumstances, one-to-one conduction may occur, but in general, there is a fixed transmission rate, 2-to-1 or 3-to-1 AV block. However, a variable degree of block can occur in some patients with this atrial flutter presenting like an irregular rhythm. The onset and termination of atrial flutter is sudden because it's a re-entrant arrhythmia. The heart rate, as I've said, is usually a division of 300. The P waves are not normal. We can see the flutter waves at 240, 340 beats per minute without an isoelectric line in between QRS complexes. And the RP relationship cannot be defined because these waves come very quickly and we cannot see if there are RP, long RP or short RP. And there are also prominent neck vein pulsations that we can see at physical examination because the atrial rate is very fast. There are two types of atrial flutter. The typical atrial flutter that depends on this calvo-tricuspid isthmus, and this is a structure at the level of the right atrium, at the level of the tricuspid valve annulus. It can be anti-clockwise and very rare clockwise, and the atypical atrial flutter that is independent of this calvo-tricuspid isthmus, and the origin of the arrhythmia can be either in the right atrium or in the left atrium, and the diagnosis is made using an electrophysiological study. But in most cases, we have a typical atrial flutter with an anti-clockwise pattern. So in this typical flutter, the atrial activity in leads 2 and 3 is a continuous undulation with a saw-tooth pattern, with sharp negative deflections, and a biphasic deflection in view 1. Like in this ECG here, you can see these flutter waves that are negative in 2, 3 and AVF. Oh, sorry, but my phone rings. Alo? Am curs, nu pot să răspund acum. Da. So, negative F waves in these leads, in the inferior leads, with a frequency of about 300 beats per minute, and positive F waves in V1. And in many cases, we have a 2-to-1 AV block, and occasionally the rhythm may be irregular. In this case, the rhythm is irregular because we have 2-to-1 and 3-to-1 block. And this is another example of an ECG with a typical anti-clockwise atrial flutter. And also in this case here. In very rare cases, we can have a 1-to-1 AV conduction, like in this case, when the ventricular rate is 300 per minute, beats per minute, so very fast atrial flutter. And in these cases, we need urgent conversion of this patient because he may be unstable, especially in elderly patients. And if you give adenosine to a patient like this in atrial flutter, you can see these F waves appearing between the QRS complexes because this medication blocks the atrioventricular junction and may cause temporary block. But in some patients, it may be dangerous because this adenosine administration may in itself lead to one-to-one conduction in patients with atrial flutter. And we have to have resuscitation equipment when trying to convert an atrial flutter. The clinical presentation will depend on the ventricular rate, of course, which is most often around 120, 150. In some cases, one-to-one AV conduction leads to extremely high rates, and the loss of effective atrial contraction in these patients, like in atrial fibrillation, leads to hypotension, angina, and heart failure in the end, with syncope when it's sudden onset, or a feeling of palpitation. Occasionally, atrial flutter can be asymptomatic for weeks or even months, and this sustained tachycardia can lead to systolic dysfunction and heart failure with a tachycardia-induced cardiomyopathy. In atrial flutter, there is a risk of systemic embolism, and we should anticoagulate these patients. What can we do in the acute management of these patients? Of course, if the patient is severely symptomatic or unstable, you should always convert the atrial flutter to sinus rhythm and try to do this in the emergency department. But in many cases, the patients are stable, and we should perform rate control. We should give the patient drugs that slow AV conduction and lower heart rate, and we should prevent recurrences and prevent the thromboembolic complications. But the specific treatment in patients with atrial flutter includes catheter ablation of this scaphotricuspid isthmus, because this is the macro-reentrant arrhythmia dependent of this structure, and if we perform ablation of this region, you should reduce to zero the risk of recurrences. And when the rate control strategy is not enough and is not effective, and the patient doesn't want to perform catheter ablation, we can perform AV nodal ablation with subsequent pacing in the right ventricle to control the heart rate. So in the acute phase, the electrical cardioversion is recommended in all unstable patients. It is highly effective, using a low energy. And there are also some drugs that are generally effective in these cases. We don't have these drugs in Romania, dofetilide and ibutylide, that are class 3 antiarrhythmic drugs that can be given in intravenous injection. We have this propafenone and flecainide, but these are contraindicated in patients with flutter in order to convert the patient, because they can lead to a one-to-one transmission atrial flutter, and the patient may become unstable when administering these drugs. The rate control in patients with atrial flutter may be difficult to obtain even when we combine AV blocking agents, and in some patients we can use amiodarone for the rate control. And also in the acute phase, we can perform high rate atrial pacing to overdrive this arrhythmia, but we can do this if we are in the presence of an implanted pacemaker or defibrillator, or even if the patient has a pacemaker implanted, we can perform it by invasive high rate atrial pacing to terminate this atrial flutter in unstable patients. And regarding anticoagulation, patients should be treated in the same as those with atrial fibrillation. This is an example of an atrial flutter cardioversion by rapid stimulation in the atria. The long-term management, it is best to perform a catheter ablation in patients with atrial flutter in all symptomatic recurrent episodes of this typical flutter. And it is also recommended to do so in patients with a depressed LV systolic function due to tachycardia-induced cardiomyopathy. And in some patients, if the patient wants an ablation and it can be done, it should be considered even after the first episode of symptomatic typical atrial flutter. So with this catheter ablation, we can reduce the risk of recurrences. The long-term management, also the rate control is important. We can use beta blockers or verapamil or diltiazem in the absence of heart failure with reduced ejection fraction, if the patient doesn't want ablation or it is not feasible. And also in some patients where the rate control cannot be obtained with these drugs, we can perform this AV nodal ablation. So we cut the AV node so that the rate can be controlled by inserting a pacemaker and stimulate the right ventricle. About rhythm control, the antiarrhythmic treatment has a pro-arrhythmic risk and is not recommended in this patient. And in some patients, amiodarone may be considered to maintain sinus rhythm if all the above measures fail, if the patient doesn't want to be ablated. The long-term anticoagulation is recommended, although the left atrial appendage is stunned and thrombi can form there, but this is less frequent compared to atrial fibrillation. But the risk of thromboembolism is still high and unacceptable in some patients. Of course, if the patient has atrial flutter combined with concomitant atrial fibrillation, anticoagulation is strongly recommended. Atrial fibrillation is the most important supraventricular arrhythmia, characterized by an incoordinate electrical activity and lack of mechanical contraction of the atria. You know that this arrhythmia is easily recognized on the ECG by measuring the RR intervals. There are irregular RR intervals when atrioventricular conduction is not impaired, of course. There are no discernible P waves. We can see these irregular F waves at a frequency of over 400 per minute. And there is a ventricular frequency with a wide range of frequencies up to 160 beats per minute. and over 200 in patients with an accessory pathway when they conduct over this accessory pathway. So this is a tracing of an atrial fibrillation, and you can see these waves here. In V1, they can easily be seen in V1, even if in other leads they are not so easily seen, here in V5 and V6, for example. So you should look for waves of atrial fibrillation predominantly in V1 lead. The epidemiology of the atrial fibrillation, you know that this is the most common sustained cardiac arrhythmia in adults all over the globe, and the currently estimated prevalence is up to 4% of individuals, and the lifetime risk for atrial fibrillation is 1 in 3 individuals that will develop atrial fibrillation during its lifetime. The risk factors, apart from the increasing age, there are a lot of comorbidities that lead to atrial fibrillation in the end, and there are some modifiable risk factors that can also lead to atrial fibrillation or temporarily may lead to episodes of atrial fibrillation, like alcohol consumption and drug consumption that can lead to frequent episodes of paroxysmal atrial fibrillation. The mechanisms are not completely understood, but the degeneration of the atrial myocardium may play a role, and also the progression of structural cardiac disease and valvular heart diseases, and the inflammation in pericarditis or myocarditis that can lead to development of atrial fibrillation. And cardiac surgery is also important, and there is also a genetic predisposition to developing atrial fibrillation. The electrophysiological mechanisms are complex. There are rapid firing automaticity in the atrial myocardium, especially at the level of the posterior left atrial wall and pulmonary veins and vena cava and coronary sinus. There are some regions that are prone to this degeneration and rapid firing. And there is an increased excitability of the atrial myocardium that is also related to atrial fibrosis. So there are a lot of complications that are considered to be linked with atrial fibrillation, apart from stroke, cognitive impairment, also dementia, depression, impaired quality of life, hospitalization, a lot of admissions for atrial fibrillation, and in the end, a higher mortality than in general population. The classification is based on the presentation, duration, and spontaneous termination of atrial fibrillation. We have a first episode of atrial fibrillation in a patient that wasn't diagnosed before, irrespective of its duration and the presence and severity of symptoms. We have also a paroxysmal atrial fibrillation that terminates spontaneously or with intervention within 7 days of onset. We have persistent atrial fibrillation that is continuously sustained beyond these first 7 days. We have long-standing persistent atrial fibrillation that its duration is greater than 12 months when we decide to adopt a rhythm control strategy, or permanent atrial fibrillation, a situation that is accepted both by the patient and the physician, and no further attempts to restore the sinus rhythm will be undertaken. The clinical presentation, these patients may have various symptoms. They may be initially asymptomatic, hence the symptoms vary with rhythm, irregularity, and ventricular rate. The chief complaints: palpitations, dizziness, syncope, dyspnea, and chest pain. And there are also symptoms and signs related to the presence of complications. Cerebral embolism is one that is very common and frightening complication, but also peripheral embolism in the arteries of the inferior limbs, and heart failure, tachycardia-induced cardiomyopathy in the process. And the physical examination gives us these signs of atrial fibrillation that are irregular cardiac sounds. The peripheral pulse is lower than the central heart rate, and there is a pulse deficit in all patients when the ventricular rate is above 80 per minute. We have this classification of the symptom scale. There is a score developed by the European Heart Rhythm Association. It does not cause any symptoms. This is class 1, 2A, 2B, when the normal daily activity is not affected by the symptoms, but the patient may be troubled by the symptoms in class 2B. In class 3, normal daily activity is affected, and in class 4, normal daily activity must be stopped, discontinued because of the symptoms. And there is also asymptomatic AF that is very important because this is independently associated with a higher risk of stroke and cardiac death, and we should screen for atrial fibrillation. And we have a variety of methods now in order to screen for this atrial fibrillation, including smartwatches and these kind of gadgets that may give us an idea about the heart rhythm. The ECG diagnosis is simple. There is a lack of normal P waves. You can see these irregular F waves, rapid, difficult to discern in some patients, especially if the atrial fibrillation is of a long duration. The ventricular response that is irregular is the exception. In patients with a complete AV block, the rhythm may be irregular because there is no conduction between the atria and the ventricles. So there is a rhythm generated by the junction, and it can be irregular. We can have a narrow or wide QRS complex if the patient has a pre-existing bundle branch block or an aberrancy of conduction. In all these patients, we can perform in some of these patients, if the atrial fibrillation is not clear, if it's not diagnosed, but it's only suggested by the symptomatology of the patient, we should perform ECG monitoring. And also we should perform this monitoring if we have to control the rate and control the adequacy of rate control in these patients. We can also perform in some patients transesophageal echo to see if the patients had a severe or not valvular heart disease, or if there is a thrombus in the left atrium, and also some other investigations that are reserved to selected patients. But in all patients, we should take a medical history, 12-lead ECG, perform tests of kidney function, thyroid function, electrolytes and full blood count, and of course, transthoracic echocardiography. The objectives of management refer to this simple ABC holistic pathway here in the guidelines, in the present guidelines, with anticoagulation that is very important to avoid stroke, with better symptom management to increase the quality of life of these patients, and also cardiovascular and comorbidity optimization in all patients. To prevent the thromboembolic complications in all patients, we should check the risk, irrespective of the type of AF. Even if the patient has a paroxysmal atrial fibrillation or persistent or permanent one, we should check the CHA2DS2-VASc score. This is depicted here in this table. We have points awarded for each of these risk factors, starting with congestive heart failure, hypertension, the age. We have two categories of age, 1 point for the patient if it's in this range, 65 to 74, or 2 points if the patient has more than 75 years old. And diabetes is also included here. A previous stroke is a risk factor for thromboembolism. Vascular disease, also a risk factor. If there is angiographically significant coronary artery disease, or a previous myocardial infarction, or peripheral artery disease, or even an aortic plaque. These are included here in the vascular disease category, and there is 1 point for this. If the patient is female, there is also kind of risk, and the female gender has a point in this score. And there is also, when we think about preventing thromboembolic complications, we should also calculate this Hasbled score that gives us an impression of the risk of patient, of the bleeding risk of patient. And there are some factors that predispose to a high rate of bleeding and a higher risk of complications. So what can we do when we are in front of a patient with atrial fibrillation in order to prevent these thromboembolic complications? In the first place, we should identify the patients with a low risk, and these are patients with a CHA2DS2-VAS score 0 in males or 1 in female patients. So if the score is 0 or 1 in female patients, then this is a low stroke risk, and the patient will not need chronic anticoagulant treatment. But if the CHA2DS2-VAS score is above 1 in males and above 2 in females, then we should think about anticoagulant therapy in this patient. And we also have to address these bleeding risk factors in all patients. And then, if we consider to give anticoagulant treatment in these patients when the score is 1 in male or 2 in female or above these values, then we should choose a drug to be given on the long term. The drug choice is between these two categories of warfarin. These are vitamin K antagonists that lower the risk of stroke and the mortality risk that are given for centuries. And they are the first choice in patients with mitral valve stenosis and mechanical valves, because we cannot give novel anticoagulants in these patients. The limitations are that these drugs have a narrow therapeutical interval. The clinical efficiency is influenced by many factors, and we have to monitor this INR, which is problematic in some patients, and we have to stay with this value above the cutoff value in this therapeutic interval to have a safety and efficacy of this treatment. Then we have the alternative of the novel oral anticoagulants. There were a lot of trials that show that these substances, these new drugs, that are direct inhibitors of the 10th factor of anticoagulation, apixaban, dapigatran, edoxaban, and ivaroxaban are non-inferior to warfarin in the prevention of stroke and systemic embolism. And in all the studies that were done until now, these were associated with a significant decrease of the risk of stroke and systemic embolism, and with a significant reduction of mortality of all causes. So in the guidelines now, these NOACs, these novel anticoagulants are generally recommended over warfarin as the first-line therapy for oral anticoagulation in patients with atrial fibrillation. When we give warfarin, the doses are for each subject are variable, and we have to perform this INR monitoring to be kept between 2 and 3 in all patients. But if the patients cannot maintain this INR in the therapeutical range, the recommended options are to switch to a NOAC or to improve this goal by education and counseling and more frequent checks of this parameter. These are the most used dosage of these substances, these drugs. You shouldn't keep this in mind, but it's only for information. What is to be said here, and it is very important, that single or even dual antiplatelet therapy is not recommended for the prevention of complications in atrial fibrillation. In fact, it is contraindicated to give an antiplatelet therapy in these patients in order to prevent stroke. So this is not recommended. We can also perform some surgical or interventional therapy in patients with atrial fibrillation in order to prevent thrombotic complications and embolism. This can be done either surgical or using a percutaneous implanted device for LA appendage, the Watchman device, for example. There are many studies with this device, with the aim of limiting thrombi formation and embolization. This device occupies the left atrial appendage and seals it in a kind of way, and the thrombi cannot move from here to, to produce embolization in circulation. So, the most common justification for left atrial appendage occlusion or exclusion in clinical practice is now if the patient has a perceived high bleeding risk, or less often if oral anticoagulation is contraindicated. And what about the long-term management apart from preventing thromboembolism? There are two strategies that can be chosen in this patient that we can choose: the rate control and the rhythm control. The rate control refers to the fact that we can control heart rate in atrial fibrillation and maintain the atrial fibrillation rhythm, or we can try to convert the atrial fibrillation to sinus rhythm. This is the rhythm control strategies, but in different studies, there are no differences regarding all-cause mortality and stroke between these two strategies, so we can choose either of these strategies. The rate control is often sufficient to improve the symptoms. It is part of all management in all patients with atrial fibrillation. The first choice strategy that we can apply in patients with minor symptoms, they are asymptomatic, and is an alternative way in patients with heart failure or after failure of a rhythm control strategy. And if you cannot obtain sinus rhythm, you can control the rate. So, in all these patients, we can aim to a lenient rate control first with a heart rate below 110, and then if the patient continues to have symptoms or if the LV function deteriorates, then we should aim to a lower heart rate below 80 beats per minute. What we can use? We use beta blockers, digoxin, diltiazem, and verapamil. These are drugs that block the AV conduction and slow the AV conduction. Some antiarrhythmic drugs also have rate-limiting properties, but generally they should be used only for rhythm control, such as amiodarone or derandarone, that are pro-arrhythmic, that have pro-arrhythmic effects in the long term. The choice of rate control drugs depends on the symptoms, comorbidities, and potential side effects. The beta blockers are first line, especially in the acute phase, and also in patients with heart failure. These non-dehydropiridine calcium channel blockers, verapamil and diltiazem, are not indicated in low EF heart failure. And digoxin, you have to be cautious in patients with CKD. And also, this is not effective in patients that have a high sympathetic stimulation. And amiodarone, it can be useful as a last resort when heart rate cannot be controlled with other combinations therapy, because on the long term, it may have pro-arrhythmic risk and risk related to other side effects that can be dangerous for the patient. And in the end, we cannot control ventricular rate. We can ablate the atrioventricular node. We can perform ablation and then pacemaker implantation. And the procedure is simple and has a low complication rate. We have to implant the pacemaker first and then perform atrioventricular node ablation. So the patient will remain in atrial fibrillation in the atria, but the heart rate is given by the stimulation of the right ventricle. So it will be an artificial induced heart rate, but the patient may feel better than with his own atrial fibrillation. And the procedure does not worsen LV function and may even improve LV ejection fraction in selected patients. The rhythm control refers to the attempt that we make to restore and maintain sinus rhythm and may engage a combination of treatment approaches such as cardioversion, even electrical or pharmacological, antiarrhythmic medication, and catheter ablation that are performed along with adequate rate control, anticoagulation, and cardiovascular prophylactic therapy. So, if the symptoms are present in patients with atrial fibrillation, and the patient and the doctor choose a rhythm control strategy, then this is done to improve the quality of life in these patients. And there are factors that are in favor of a rhythm control strategy in our patients with atrial fibrillation. If the patient is young, if it's the first episode, or the atrial fibrillation has a short history, if the patient has a type of cardiomyopathy that is tachycardia mediated, if the patient has no or very few comorbidities, if the rate control is difficult to achieve, and if the patient's decision is to be in sinus rhythm again and to try to achieve sinus rhythm, then we should think of this strategy of rhythm control. We can do this by cardioversion. In the acute phase, it can be performed as an emergency cardioversion in a hemodynamically unstable patient, or in a non-emergency situation as elective cardioversion. We should use synchronized electrical cardioversion in all patients with atrial fibrillation, and it is more effective than pharmacological cardioversion and results in immediate restoration of sinus rhythm. Of course, the patient may have recurrences of atrial fibrillation afterwards, but the cardioversion is, for the moment, it may be successful. We should think of a pre-treatment with antiarrhythmic drugs before cardioversion to improve the efficacy of elective electrical cardioversion. In all these patients, mostly if they are stable, we have to think about anticoagulation before cardioversion to prevent thromboembolic episodes. And pharmacological cardioversion is an alternative in patients that do not desire to be cardioverted electrically, and the efficacy of this method is higher among patients with a recently diagnosed atrial fibrillation, but it is lower in patients with a long history of atrial fibrillation. What are the drugs that are used? Flecainide, amiodarone, vernaculant. These are the most frequently used in clinical practice. This is a class 1C agent that is indicated in patients without significant LV hypertrophy or LV systolic dysfunction or ischemic heart disease that results in prompt and safe restoration of sinus rhythm. And amiodarone may be indicated in patients with heart failure, has a limited and delayed effect, but can slow heart rate within the first 12 hours of atrial fibrillation. And this newer drug, vernaculant, is the most rapidly cardioverting drug, including in patients with mild heart failure and ischemic heart disease, and it's the most effective from these three drugs. In some patients, if the episodes of paroxysmal atrial fibrillation are frequent, one can use a self-administered oral dose of flecainide or propafenone that is slightly less effective than in the hospital pharmacological cardioversion, but may be preferred on the long term to permit an earlier conversion of the patient at home, provided that the drug's safety and efficacy has been established in the hospital setting. The interventional treatment in atrial fibrillation includes the catheter ablation, that is a well-established treatment for the prevention of atrial fibrillation recurrences. And the goal of this strategy is to eliminate this foci of automaticity responsible to the initiation of AF. And this includes the complete isolation of pulmonary veins by linear lesions around the antrum, either using point-by-point radiofrequency ablation or single-shot ablation devices. So there are a lot of techniques that tend to be safe and superior to antiarrhythmic drugs, and that can restore and maintain sinus rhythm in some patients. So catheter ablation is indicated in patients with failed medical therapy if they are intolerant to antiarrhythmic drugs and to improve symptoms of AF recurrences in patients with paroxysmal atrial fibrillation or persistent atrial fibrillation, and after after the beta blocker treatment to improve symptoms of AF recurrences fails, in these patients we can choose catheter ablation. And as first-line therapy in some patients to improve symptoms in selected patients that have paroxysmal atrial fibrillation episodes or persistent episodes without major risk factor for recurrence, and to reverse LV dysfunction in AF patients when there is a tachycardia-induced cardiomyopathy, and in selected atrial fibrillation patients that have heart failure with reduced ejection fraction to improve survival. So, this was all about atrial fibrillation. I don't know if we have enough time to discuss about some frequent supraventricular arrhythmias, atrioventricular nodal reentrant tachycardia, and atrioventricular reentrant tachycardia that are the most frequent SVDs. This atrioventricular nodal reentrant tachycardia is the most frequent type of supraventricular tachycardia in clinical practice. It appears in the first 20 years of life, but the onset may be at any age. It has a sudden onset and termination, and the heart rate may be very high, up to 240 beats per minute. The P waves, as I've said earlier, may be included in the QRS complex, and if there are P waves that are visible, the RP interval is short in most cases. So this type of arrhythmia has at its basis this dual physiology of the AV junction. There are two types of tissue in the AV junction, one that can conduct very fast and has, this is the diagram here, the normal fast pathway and the slow pathway. And this fast pathway has a fast conduction velocity, but a long refractory period, while this slow conduction pathway has a slow conduction, a low velocity of conduction, but a short recovery period. So under some circumstances, the AV node that has this dual physiology may become the center of this arrhythmia when there is a re-entry phenomenon here in the AV junction, and the AV node sends impulses to both the atria and the ventricles at the same time. There are two types of atrioventricular nodal reentrant tachycardia. The slow fast, which is the most frequent, with conduction antegrade to the slow path and retrograde to the fast path, and the fast slow, which is very rare. This is a typical atrioventricular nodal reentrant tachycardia where we cannot see, or we can very hardly see these P waves here after the QRS complex was an R prime wave, but the QRS complex is narrow, the tachycardia is very regular, and this is an example of a typical atrioventricular nodal reentrant tachycardia. So the retrograde P waves are constantly related to QRS and are either masked by the QRS or they can be seen as a small terminal wave that is not present during sinus rhythm just after the QRS complex. In the atypical form, the retrograde P wave appears far behind the QRS, and there are negative waves in the inferior leads. But only about 6% of all patients are diagnosed with atypical form. So in most cases, there is a typical form of this tachycardia. In atrioventricular reentrant tachycardia, there are These types of SVTs imply the existence of accessory pathways that conduct very rapidly between the atria and the ventricles. This is the second most frequent type of SVT. The ventricles are normally activated through the AV node, but the impulse travels back to the atria very rapidly via the accessory pathway with concealed conduction. This is the orthodromic or atrioventricular reentrant tachycardia, or the ventricles are activated through this accessory pathway, and this is antidromic or atrioventricular reentrant tachycardia. And the clinical presentation is similar to all SVTs. If the patient has an accessory pathway that conducts antegrade, it will be on Wolff-Parkinson-White syndrome with a delta wave for the beginning of the QRS complex with this slurred upstroke of QRS, and the complex seems to be wide, above 120 milliseconds, and the PR interval is short. So this is the Wolff-Parkinson-White syndrome, and there are two types of this tachycardia, as I've said earlier, orthodromic and antidromic. Antidromic is the wide QRS complexes with maximum pre-excitation, like in this short stripe of ECG here. So this is a case of orthodromic atrioventricular reentrant tachycardia when the heart rate usually is above 200 beats per minute to 300 beats per minute. The P waves are included in the QRS complex, or they appear retrograde after the QRS. There are, in most cases, inverted T waves and ST deviation, and the QRS is narrow. The response to vagal maneuvers is important. In these patients with a narrow QRS tachycardia, we should perform vagal maneuvers for a diagnostic scope. There are several possible responses of narrow QRS tachycardia to vagal maneuvers. There is slowing of AV nodal conduction and induction of intermittent AV block, and the atrial activity can be unmasked. There may be a temporal decrease in the atrial rate, or there may be a sudden tachycardia termination. This can happen by interrupting the re-entry circuit in these tachycardias that are re-entrant, and in some cases no effect is observed. So we can judge the possible diagnosis using these possible responses to vagal maneuvers and adenosine. And this may be very useful in diagnosing this kind of supraventricular tachycardias. This is a case of antidromic or atrioventricular reentrant tachycardia. When there is a wide QRS complex, the heart rate is usually above 200, and the QRS is wide. The electrophysiological study is the ultimate investigation that gives us the clue of the diagnosis. It's an invasive investigation. It uses these catheters that are inserted through the cardiac chambers to perform a passive recording of intracardiac electrical activity, measuring the time intervals between different events, or to perform an active stimulation and pacing in order to provoke arrhythmias and establish the abnormal electrical circuits before ablation. There are several techniques and maneuvers that can be employed to differentiate different kinds of SVTs, and these are recommended in patients that have hemodynamically unstable narrow QRS SVTs, in whom medication fails to stop recurrences, or the patient prefers the ablation. And also in patients with wide complex QRS, to establish a correct diagnosis in order to provide a correct therapy, and also in patients with Wolff-Parkinson-White syndrome, if the patient has an unexplained syncope or a familiar history of sudden cardiac death. The acute management of supraventricular tachycardias, when we don't have a diagnosis, we should perform vagal maneuvers if the tachycardia is with narrow QRS complexes, and then we should think about medical treatment that is given intravenously. Adenosine is the first-line treatment, beta blockers, verapamil and dimethiazine. And finally, electrical cardioversion in unstable patients. Beta blockers are contraindicated in acute heart failure, and these calcium channel blockers are contraindicated if the patient has low BP and heart failure with reduced ejection fraction. Vagal maneuvers can be performed by performing a carotid sinus massage with a maximum of 5 seconds on unilateral, and is to be avoided in elderly patients and patients with a history of strokes. It is very effective in adults and in these reentrant tachyarrhythmias. Or we can perform a standardized approach, putting the patient to blow into a 10 milliliter empty syringe with sufficient force to move the plunger, and then reposition the patient in a decubitus position after the maneuver with passive leg elevation to prevent hypotension. And this is a standardized vagal maneuver, and this may terminate tachycardia or may give us a clue about diagnosis. Adenosine is given in a rapid bolus with immediate saline flush and is the first drug of choice in supraventricular tachycardias with a nerve complex. It can provoke pharmacological cardioversion of reentrant SVTs that use the AV node as part of their circuit and has a very short plasma half-life, and the end organ clinical effects complete within 20 to 30 seconds. This drug slows the AV conduction and can provoke an AV block and the interruption of the reentrant loop. As adverse effects, it can provoke bronchoconstriction in some patients, and it should be avoided in patients with asthma. It can provoke a sensation of chest pain, transient dyspnea, and facial flushing that can be impressive in some patients. And also, in rare cases, it can lead to atrial fibrillation. The alternatives are the calcium channel blockers, verapamil or diltiazem, that may lead to the termination of SVT in a large percent of cases, but hypotension may be a potentially adverse event, and it is to be avoided in patients with low blood pressure or in patients that are hemodynamically unstable, and some beta blockers that can be administered intravenously, esmolol or metoprolol in the acute phase. They are contraindicated in patients with acute heart failure. In wide QRS tachycardia, we should perform electrical cardioversion with a synchronized electrical shock if the patient has a persistent tachycardia with a wide QRS complex with shock, hypotension, altered mental status or chest pain or acute HF. If the patient is not hemodynamically unstable, we should perform vagal maneuvers. If they are ineffective, we should treat the patient like VT if we are uncertain of the diagnosis. Vagal maneuvers can help differentiate between these types of SVT transmitted with aberrancy, but some drugs may lead to instability of the patient, and they cannot be used if the ventricular tachycardia is suspected. And also, adenosine must be avoided if pre-excitation is suspected, because this can lead to atrial fibrillation and cardiac arrest in patients with a pre-excitation syndrome. There are some drugs that can be safely used in these patients, and these are procainamide and amiodarone with intravenous administration in the hospital, of course. And for the long-term treatment in supraventricular tachycardias, if the patient is not very symptomatic, we can give a non-pharmacological treatment with measures for the prevention of recurrences, avoidance of catecholaminergic substances, treatment of hypothyroidism if this is present, and the patient's education to perform vagal maneuvers. Or if the patient has a wish to perform ablative therapy, if there are frequent episodes of supraventricular arrhythmia, then we should perform an electrophysiological study and determine the mechanism of the arrhythmia and try to ablate this arrhythmia. If episodes of SVTs are infrequent and short-lived, no-medical treatment is recommended, but catheter ablation is recommended for all patients with symptomatic recurrent atrioventricular nodal reentrant tachycardia, or in patients that do not want to be ablated, diltiazem, verapamil should be, or beta blockers should be considered. The catheter ablation of the accessory pathway is recommended in patients with symptomatic recurrent atrioventricular reentrant tachycardia, and in these patients, if there is no sign of pre-excitation on the baseline ECG, we can give beta blockers or calcium channel blockers if ablation is not desirable or feasible, but if there are any signs of pre-excitation, these medications should be avoided. And also in these patients with atrioventricular reentrant tachycardia, we can give propafenone or flecainide if there is no ischemic or structural heart disease and ablation is not feasible. But there are some medications that are not recommended and potentially harmful in patients with pre-excited atrial fibrillation, and these are digoxin, beta blockers, and calcium channel blockers, and even amiodarone that may be dangerous in these patients in the presence of atrial fibrillation with pre-excitation. There is an algorithm here that will give you some clues of orienting on ECG. And also I've put this slide with the classification of antiarrhythmic drugs in these 4 classes, just to remember pharmacology of antiarrhythmic drugs. Okay. So, anyone there?
Yes.
Yes.
So, do you have some questions now, or I will give you the presentation in its PowerPoint or PDF format, and you can also, I don't know, read what's on the slides, because this should be enough. The most frequently found subjects from this chapter are the treatment of atrial fibrillation, or regarding the CHADS-VASc score. These are the mainly preferred subjects from this supraventricular arrhythmia chapter. And also the treatment in the acute phase of supraventricular tachycardia. But if there are any things that are unclear, I will send you my email and you may ask questions, if there are no questions now.
Thank you.
Thank you.
Thank you.
Okay.
Thank you.
Have a good day. Thank
Have
you.
a nice day.
Have a nice day too.